get started. Good afternoon, everybody, thank you and welcome to join us today for our third session for the CRCR certification series. We're going to do two different sessions. This week we'll be doing part of Unit 2, pre-service and financial care. Next week we'll be doing the remainder of it. My slide deck to move there, Diane, sorry. Let's start with some technical difficulties here, guys. Okay, sorry about that. So Unit 2, pre-service financial care, we're going to be reviewing types of patients. We're going to be reviewing scheduling, and we're going to be reviewing pre-registration. Next week, you go from health plans through patient financial communication. We will be, as a reminder, just taking CRCR sessions every week will not get you to pass the CRCR certification. You should have signed up for the course on HFMA and access it via your e-learning once you've signed up for it. We highly recommend that either you do the module prior to joining this session or do it after this session so that you can reinforce the materials that we're walking through today. There's a significant amount of materials that we cannot review due to its entirety during our sessions. However, should you take this course along with the online course and do a little bit of studying, I'm pretty sure you'll be successful in passing the exam. Reminder, we are taping these. I'm recording these, so please stay off of mute and off of camera for the beginning of the sessions. Feel free to put any questions in the chat. We'll be monitoring those for you. Or you can ask them at the end of the session and feel free to come off camera, come onto camera, come off mute, and ask your questions live as well. These will be available, the material is available on the Florida HFMA website. And the recordings are available on the Florida YouTube channel. So if you happen to miss a session or you want to use this for some study sessions after it, those will be available for you to take. All right. So in this sections, we're going to address the different types of scheduled and unscheduled patients within an acute care healthcare facility. And then we'll talk about non-acute patient types as well. So a patient's first contact with an acute healthcare facility is either as a scheduled or unscheduled patient, depending on whether immediate care is needed or if the services can be scheduled for a future date or time. Many patients receive healthcare services that are not scheduled ahead of time, including urgent, direct admits, walk-ins for routine labs and x-rays, and of course, newborns. There are several health services available to patients which are not normally provided in acute hospital setting. These are non-acute, and these include skilled nursing, hospice care, home health services, clinic services, and durable medical equipment. Patients are considered scheduled if the healthcare facility knows that the patient is coming ahead of time. Healthcare facilities normally schedule services that are high dollar and require significant pre-processing to ensure appropriate reimbursement and or significant resource coordination. Scheduled patients can be registered as inpatients, outpatient, or recurring series patient types, things like physical therapy, behavioral health, chemotherapy, and radiation therapy. Patients are scheduled as inpatient if their level of care meets inpatient acuity criteria. Most facilities use Medicare standards as the guidelines for determining inpatient status. Major surgery patients and obstetrical patients are the most commonly scheduled inpatient. Direct admit patients can be considered scheduled if the physician calls the facility ahead of time to let them know the patient is coming. Patients are scheduled as outpatient if the service they receive do not involve an overnight stay. Patients arrive for service, receive treatment or testing, and go home. Examples are routine diagnostic testing, pulmonary function testing, interventional radiology, ambulatory surgery, and labs. Certain services where the treatment is ongoing are registered as recurring or series patients, which are considered outpatient. Once registration is completed and charges related to the ongoing treatment are entered on one account for multiple days of service, they can typically be re-registered on a monthly basis if the treatment duration exceeds 30 days. Again, these include therapies, behavioral health, IV therapy, chemotherapy, and radiation therapy. The emergency department is the most common source of unscheduled admissions. Patients arrive at the ED seeking care, and if the patient meets the acuity criteria for admission, and an order is written to admit the patient. When the patient is admitted, the admission will be considered an emergency admission. Most health plans require a notification of emergency admissions within a specific time period, usually within 24 hours or the next business days. Failure to do so may result in denied days and lost revenue. Certain types of services, such as routine X-rays and laboratory tests, are typically provided without the benefit of prior scheduling. They are considered walk-ins. Typically, these services do not require any approval from the health plan, but may require the patient to receive services at a contracted or in-network facility. Observation is used to evaluate patients for possible inpatient admissions, to resolve a medical problem so that the patient may be discharged, for treatment that is expected to last less than 24 hours, and to treat complications following outpatient surgery or procedures. Remember the Medicare's 2-night rule as it relates to observation patients. Non-acute care. Patients are admitted into skilled nursing facilities or SNFs when they no longer meet the criteria for acute care, but still need an inpatient level of skilled nursing care or rehab services. These usually include orthopedic surgical patients who require intense physical therapy and stroke patients who require comprehensive rehabilitation services. Typically, and this is a big typical right now, Medicare will only cover services in a skilled nursing facility if the patient was transferred after at least a 3-day inpatient stay for a related illness or injury. We do know that with the pandemic, some of these restrictions were removed to facilitate care. However, the regulation has not been permanently changed, so the 3-day inpatient stay rule is still in effect. It has been relaxed. Hospice care is intended to provide humane and compassionate care for patients who are in the last stages of an incurable disease and have a life expectancy of 6 months or less. Hospice services support the patient with pain relief and symptom management, but the disease is no longer treated. If a hospice patient receiving services under the Medicare program is admitted to the hospital for hospice-related services, the hospice program is billed, not Medicare. Home health services can cover a wide range of healthcare services, which can be given in a home for illness or injury, such as physical therapy or speech pathology. Medical equipment is deemed durable medical equipment, or DME, if it is intended to be used over and over again. Examples include wheelchairs, hospital beds, and oxygen tanks. And then finally, a clinic is a facility, a part of one, that is devoted to the diagnosis and treatment of outpatients. Okay, key points. The patients are considered scheduled if the healthcare facility knows that the patient is coming in ahead of time. Scheduled patients can be registered as inpatients, outpatients, or recurring series patient types. Many patients receive healthcare services that are not scheduled ahead of time. These patients include unscheduled inpatients or urgent patients, unscheduled outpatient or walk-in patients, emergency patients, observation patients, and newborns. Again, non-acute health services include skilled nursing, hospice care, home health services, clinic services, and DME. Hopefully, we've given you some idea of the various types of patients and the importance of scheduling patients to ensure appropriate resources are secured when you can. All right, we're going to move on to a polling questions. Which patients are considered scheduled? Recurring series patients, hospice care, observation patients, or emergency department patients? Okay, we'll close that up. And the answer is, you got it, recurring series patients. Patients who receive services where the treatment is ongoing are registered as recurring or series patients and are categorized as scheduled outpatient. Services for scheduled patients are high dollar and require significant pre-processing to ensure appropriate reimbursement or significant resource coordination. All right, one more polling question. How many days must a patient be inpatient for Medicare to pay for a SNF? Okay, we'll close that out. Correct answer is 3. Again, changes to the 3-day rule during the pandemic were allowed, but regulation, still the correct answer is still 3 days for them to pay for a SNF. Okay. Right. And moving on. All right. In this section, we're going to address scheduling processes, including patient identification, the requested service, medical necessity screening, and Medicare Advanced Beneficiary Notice. Scheduling patients for service allows the facility to prepare for the patient's service by reserving time and obtaining information, equipment, and resources required to provide the service. It also allows the facility the time to review the appropriateness of the service, screen for managed care requirements, and resolve any financial issues prior to service. Completed daily schedules are used by the service department and the arrival area. If the patient does not go directly to the department, to complete final preparations for the patient's arrival. Each component of the scheduling process will be discussed in some detail in the CRC study materials, as these activities form the basis for pre-service registration and financial processing. So the core concept steps that we're going to review in more detail, and these are clear components that should be done when a patient is scheduled, is identifying the correct patient, requesting the service that's been ordered by the physician, scheduling instructions to the patient, review and validation, patient's reminders and arrival instructions, and then order requirements. So the first step in scheduling is identifying the patient. Healthcare information systems maintain historical databases for every patient who has had services within the healthcare system. Critical patient information, including the patient's legal name, date of birth, sex, and social security number, is collected and used as patient identifiers. Each patient is assigned a unique number, commonly called the Master Patient Index Number, or MPI, or the Corporate Patient Index Number, or CPI. Individual episodes of care are linked to the MPI or CPI number to enable the provider to identify all services provided to an individual patient within the healthcare system. When there is a request for service, the scheduling staff member must confirm the patient's unique identification record to ensure that he or she accesses the correct information in the historical database. Obtaining and confirming accurate patient information is extremely important in order to avoid data errors such as duplicate medical record numbers or choosing the wrong patient. Once the correct patient is identified, remaining demographic information is obtained, validated, or updated as necessary. Following is a list of typical demographic information: patient legal name, date of birth, social security number, sex, marital status, complete address, telephone numbers, race, occupation and employer, and emergency contact information. A physician order is generated and becomes the basis for the request for service. The contact for the request for service can come from the patient, physician's office, or a service department in the healthcare facility. If the patient is scheduling the service, he or she is given a written physician order, or the physician faxes the written order to the scheduling department and is asked to call and schedule the service what is convenient for the patient. Patients usually schedule services such as ultrasounds, mammograms, stress tests, and therapy. The physician office typically schedules surgery cases, catheterizations, and other invasive type procedures. The type of requested service will determine the scheduling instructions. Instructions to the scheduler range from the basic, such as the amount of time needed for the test, to the complex, when rooms, equipment, and personnel must be coordinated to provide the needed service. Many healthcare organizations use automated scheduling system and build the scheduling questions in the system. The scheduling system prompts the scheduler to complete required scheduling instructions each time a test or procedure is requested. If an automated scheduling system is not used, a binder, including all scheduling instructions, should be maintained to facilitate the scheduling process and ensure all critical instructions are completed. One example of scheduling instructions would be for a nuclear medicine procedure. Contact the department to order the isotope. Reserve the procedure room for X number of minutes. Inform the department if patient is in a wheelchair, and provide medication instructions based on type of test order. Scheduled procedures routinely include patient preparation instructions that must be completed prior to the test procedure. By providing accurate instructions during the scheduling process, the scheduler ensures that the patient will be properly prepared for the service and does not need to be rescheduled. Examples of commonly used patient instructions include: refrain from eating or drinking anything after midnight, taking all prescription medications on the day of the test, at least 90 minutes prior to the examination, drink 24 ounces of water. Before finalizing the scheduling contact, all components of the scheduling contact are reviewed and validated. This important step is used to verify that the patient has complete and accurate information. The following information should be reviewed as part of a scheduled finalization: the service to be provided, date and location of the scheduled service, arrival time and procedure time. Verify patient is clear on the scheduled test time versus the required arrival time, should there be prep work needed to be done. Required pre-service testing, including completion timeframe. Patient preparation instructions and patient arrival instructions, such as where to report, where to park, and how to get to the service area. The patient reminder is a written list of the patient's responsibility and usually includes the same items summarized at the end of the scheduling call, along with any additional instructions provided as part of additional access processing activities. Example, required insurance forms, expected time of service, payments. Reminder letters can also include maps that show the patient where to park, where to report when he or she arrives, and where the service department is located. These notices may be used to reduce the incidence of no-shows or non-compliance with testing instructions. Many facilities call the patient a day or two prior to the scheduled visit to remind him or her of the appointment. Before finalizing the schedule contact, all components of the scheduling contact are reviewed and validated. This important step is used to verify that the patient has complete and accurate information. Again, the listed information should be reviewed as part of the schedule finalization. These are very key things for a facility to do. If a patient is a no-show, that has lost revenue to that organization, that procedure room, that testing room has all been resourced for that individual exam, and valuable revenue and resources are sitting around doing nothing, and revenue is not being earned when expected. So there's a lot of time and attention spent in validating and ensuring that patient is compliant and shows up for the exam. Again, the patient reminder is a written list of the patient's responsibility, and again includes the same items summarized at the end of the scheduling call. Okay. Tests and services can only be provided with a valid physician order. The few exceptions are requests from Medicare beneficiaries for things like flu vaccines, pneumonia vaccines, or screening mammograms. Initially, verbal orders can be taken as long as they are accepted by qualified staff as defined in the facility's medical staff bylaws, rules, and regulations. All verbal orders must ultimately be authenticated by the ordering physician by subsequent written signature, fax signature, or computer signature. Medicare requires the full following data elements to consider a valid physician order: patient legal name, date order written, test or service ordered, diagnosis, coded diagnosis, or narrative description of the reason for the test or service, name of the ordering physician or allied health professional, and signature of the physician or allied health professional ordering the test or service. Orders may be written on a prescription pad, documented on a pre-printed form, or electronically generated and transmitted by the physician's practice's computer system. Again, these orders must include the physician address and telephone number, physician's NPI number, date of birth, patient sex, social security number, patient demographic, health plan information. Medicare will only pay for tests and services that it determines are reasonable and necessary. Medicare has established guidelines called local coverage determinations, or LCDs, and national coverage determinations, NCDs, that establish which diagnosis, signs, and symptoms are payable. If a test is ordered where an LCD or NCD exists, there must be documentation of medical necessity in order for Medicare to pay for the test or service. If a test or service is not medically necessary according to the LCD, NCD, a signed advance beneficiary notice, or ABN, must be obtained from the patient. An ABN is not used for inpatient services or for tests that are always excluded from Medicare payments, such as acupuncture, experimental tests, and research testing. Medicare does provide other forms for those situations. The purpose of the ABN is to give the patient advance notice that Medicare may not pay for the test or service ordered and the associated cost, which will be billed to the patient. The ABN must be issued to the patient before providing services related to the ABN. Generic, routine, and blanket ABNs are not acceptable except in cases such as frequency limitations where all patients are at risk. Failure to provide a patient with a signed ABN will result in that test being denied, and you cannot bill your patient. An ABN is not used for inpatient services. The inpatient counterpart to the ABN is the hospital issued notice of non-coverage, or HINN, and should be provided to beneficiaries prior to admission, at admission, or at any point during an inpatient stay if the hospital determines that the care the beneficiary is receiving or is about to receive is not covered. And I'll give you a good example that I truly dealt with. So grandma was in the hospital and her family was notified on Friday that the physician put in the orders for her to be discharged on Friday. When the family was contacted, they informed us that they were going away for the weekend and that no one would be able to pick up grandma until Tuesday. So clearly that is an example of the remaining stay being custodial in nature. But you know, my thoughts on that family certainly were not very positive at that point in time. So key points that we want to remember: Medicare has established guidelines called local coverage determination and national coverage determinations, LCDs, NCDs, that are used to determine which diagnosis, signs, or symptoms are payable. Tests and services can only be provided with a valid physician order. And then key patient information, including the patient's legal name, date of birth, sex, and social security number, are collected and used as patient identifiers. And we've got another polling question here. Name the guideline that Medicare established to determine which diagnosis, signs, or symptoms are payable. Okay, we'll wrap that one up. Awesome, great. Local coverage determination. Medicare and other health plans will only pay for tests and services that are determined to be reasonable and necessary. Medicare has established guidelines called local coverage determinations, LCDs, and national coverage determinations to allow you to know this prior to service. Once you know it prior to service, then you would provide the patient with the advanced beneficiary notice. Hey, let's get into pre-registration. We're going to talk about the pre-registration purpose and process, very important in healthcare. Information collected during pre-registration, consequences that an organization may experience due to inaccurate or incorrect patient information, and an overview of the Medicare secondary payer screening process. Pre-registration should be completed for all scheduled patients prior to their arrival for service. Obtaining the patient's demographic and insurance information prior to service is one of the key steps to ensuring accurate and timely billing. A best performance indicator is that 98% of all scheduled patients should be pre-registered. A successful pre-registration program also identifies the potential need for financial assistance and provides the staff with the opportunity to give patients preparation instructions. In addition, proper pre-registration, collecting estimates up front, having financial conversations with patients prior to their arrival for service is the best thing to do for your patient. The patient can now focus on the clinical care, the test, or the procedures that they're going to have, and not worry about the financial ramifications to them down the line. The process of pre-registration ensures that patient access staff will have complete and valid information needed to finalize any remaining pre-access activities, including Medicare secondary payer screening, or MSP, medical necessity screening and providing the patient with an ABN, insurance verification, pre-certification and authorization requirements, because we know if we don't get pre-auth completed prior to service, we will get denied and probably lose that revenue. Any other managed care requirement resolution, including notice of non-coverage based on their medical guidelines, and then financial education resolution, and those financial conversations with patients. The purpose of the initial pre-registration step is to identify if the patient has been a previous patient and has an existing master patient index or MPI number. Again, each patient with a historical record in the facility's registration is assigned a unique MPI number, and all patient information is documented using this number. A search for the patient's MPI is initiated using the patient's full legal name and date of birth, or the patient's social security number if available. Many patients have similar names, and the only way to make sure the correct patient record is accessed is to validate using multiple identifiers. If the patient's record cannot be found with that information provided, always ask the patient if he or she has had previous services at the facility, or if his or her record could be listed under a different spelling, maiden name, nickname, just changing a name. I used to have a hospital in Maryland, and patients would be registered as Bubba, even though the patient's real name was John. And so we'd have to find him under Bubba and then obviously get it corrected to John. So the first critical steps, again, is verifying that patient's identification. Express check-in should be established for scheduled and pre-registered patients, either in a designated area or within the service department. Because pre-service processing has been completed, the only remaining registration steps include confirming positive patient identification, activating the record, placing patient armband for correct identification during the provision of services, obtaining signatures, and finalizing any financial resolution obligations. So now we all know that with the pandemic, many processes and changes have occurred within the organization to try to do as much touchless and contactless. So many of those processes may no longer be in existence, but just to make this, these were what was in the, certainly the training materials to date. For patients with no MPI number, a new medical record will be generated. Again, patient's full legal name, again, not Bubba, at least I hope I not. Minimum requirements, including sex, gender, date of birth. Additional information includes race, ethnicity, social security number. And we also, again, know that there are a lot of changes to the data that's being asked for, or even the data that the patients are willing to provide you with, i.e. race, ethnicity, social security number, or things that facilities may not be asking anymore, or patients may not be willing to provide. Serious consequences may occur if patients are identified incorrectly via the generation of a duplicate medical record or by the selection of the wrong patient record. Treating a patient with the wrong medical history, a patient can have serious adverse reactions to treatment since their allergies and medical conditions are not correctly identified. If insurance information is wrong, then a patient claim is sent to the wrong health plan. Explanation of benefit statements are sent to the wrong patient, thus resulting in a serious breach of confidentiality and is considered erroneous billing and is taken very seriously by regulations. And incorrect medical services are added to the wrong patient's medical record, again, potentially perpetuating adverse medical outcomes. Once the registration process is completed, insurance verification is conducted to ensure the accuracy of the insurance information. Coverage issues are identified and communicated to the patient. This sets the stage for completion of financial education and account resolution based on deductibles, co-insurance, or other coverage limitations. Insurance verification can be completed through electronic inquiry or telephone contact. Most major health insurance payers, including Medicare and Medicaid, offer electronic verification via the ANSI 270-271 transaction set. Electronic inquiry provides the fastest and most cost-effective and efficient way to complete insurance verification and should be used whenever available. Electronic verification may be automated through the registration system or initially initiated manually via the payer's website. Sequencing plans involved in the coordination of benefits are COB situation, so that the primary, secondary, and potentially tertiary plans are correctly recorded and billed. Recording patient out-of-pocket liabilities such as deductibles, co-payments, co-insurance, and coverage limitations allows for a more accurate estimate of the amount the patient may owe. And again, identifying pre-authorization and pre-certification requirements based on the patient's plan, prefix, service, and location are key to ensure you avoid back-end denials that have limited capability to overturn. For Medicare patients, an important component of the pre-registration process is the effective completion of the Medicare secondary payer, or MSP screening process. The basic MSP rules are discussed in course 1.6, Medicare compliance and regulations, which you've already should have completed. For patient access staff, understanding both the MSP rules and how to ask the MSP questions are essentials. Many facilities have developed computerized MSP forms that guide staff through the required questions. You will be audited by Medicare to ensure that the MSP process is occurring for your patients. So we do review the topic of MSP multiple times. So I would give you, the recommendation to really understand the MSP rules as they apply to COB. So anyone who has worked in patient access will tell you that the patients don't really understand this. My father was always giving his Medicare card and failed to inform them that my mother had an employer group health plan that was primary since she was still working and we met the criteria for it. So the current rules for MSP is if a patient or spouse is working over the age of 65 and has chosen to take the group health plan, now they don't have to, and they cannot be afforded as a supplement. So if they choose not to take it, but if they do choose to take it and the employer has more than 20 employees, then the employee group health plan is primary over Medicare. If the patient is under the age of 65, has Medicare through disability, and has an employer group health plan where the employer has more than 100 employees, then the employee group health plan is primary over Medicare. If a patient has Medicare through ESRD and has an employer group health plan, then the employer group health plan is primary during the 30-day month coordination period. Again, ESRDs, end-stage renal disease. Once they have met the 30-month coordination period, Medicare then becomes the primary payer. If a patient has liability coverage due to either an auto accident or a workers' compensation premise accident, then the liability coverage must be billed first. If a patient has an accident in their own home, then liability would not apply and Medicare remains the primary. Again, liability must be either an auto accident or a workers' comp premise accident for liability to be primary. Insurance denials can, and unfortunately occur quite often still in the industry, for missing invalid subscriber information. They are ineligible on dates of services. We didn't meet the authorization requirements. Maintaining and understanding when auth is required is a very difficult component that providers still struggle with today. Not following out of network status, and certainly Hopefully many of you will be joining us for the no surprise billing conversation and presentation on Thursday, because we know that's a hot topic that's really related to the out-of-network status that we're all trying to figure out what are we going to do there. So more to come on that. Certainly medical necessity failure that was not brought up and the patient did not agree to pay for that. And then certainly coverage limitations. So obviously the downstream impact is return mail and inability to collect self-pay amounts from patients, insurance denials that may or may not be overturnable. And then again, unnecessary health plan follow-up and rebilling result in higher rework cost. There are stats out there to say the cost to rebill a claim is about $50 per. So from an administrative standpoint, we should be trying to avoid it. You got to get it right up front versus chasing the dollars on the back end. So as I did already said, the average cost to rebill a claim, if you can, is $50 per. So when the claim is reworked, analyzing the denial, requesting additional information, reviewing notes and documentation, appealing the denial, preparing and resending the claim, the amount earned by the provider is dramatically reduced. And the one thing about the appealing of denied claims, most provider organizations and follow-up staff don't just do it once. They do it multiple times, many times resulting in a negative cash value if they're trying to follow up on a claim where the actual reimbursement is less than the cost to try to rework it. So avoiding those denials, get into a denial prevention strategy, not a denial management strategy. So the key points that we went through in this section is the importance of pre-registration and the impact and the issues that can impact the organization if we don't do it right up front. The right thing to do for your patients, obviously collecting that cash up front. The more cash you collect up front, the less cost to collect on the back end. So the importance of patient access, I don't think patient access gets enough recognition for what they do in an organization. And if they don't do it right, the downstream impacts. So many organizations, I was one of them, recognized that I needed my more seasoned, educated staff on my front end. They got it right up front. My staff on the back end didn't have as much work to do. So investing in your patient access solutions and your teams and your members and training and certification is really going to be a value to any organization. And polling question, what is the purpose of insurance verification? All right, let's close that up. Right, most of you got it right. So now, people that answered that to effectively complete the MSP screening process, although that is a component of potentially the insurance verification and pre-registration processes, it only applies to patients that have Medicare. So the correct answer is number 4. During the process, coverage issues are identified and communicated to the patient. Insurance verification sets the stage for completion of financial education and account resolution based on deductibles, co-insurance, or other coverage limitations. And I think we might have one more polling question here. When is Medicare not the secondary payer?
Christine, it's not letting me launch the poll.
Okay. All righty. Technical difficulties again. Sorry about that. The correct answer is number 2. Accidents in the home are not covered under liability and Medicare would be the primary payer. So I want to make sure that we're reading the questions correctly as you get into the exam, as we go through these, practice questions that are coming from the module. There's many more out there that you want to take, right? And there's things that, when you get into other things, that there'll be some exercises to validate that. We really can't go through in the time here, but really read the questions. So that, again, when is Medicare not the secondary payer? It's when a patient has an accident in their home. Okay. And I think that is all. Are there any questions in the chat? I don't see any. Anybody have some burning questions that they want to review live with us? Feel free to come off mute. Show your faces if you want. All right, so Diane, I'm presuming there's no questions in the chat?
Nope, no questions.
There you go. All right, well, I hope you all have a wonderful day. Hopefully you found this valuable. Next week, we'll have another presenter going through the remainder of the patient access solutions for you. So hopefully we'll see you next week. I hope everybody has a great day and great week, and we'll see you next week.
Thank you.
Thank you, guys. Take care.